Thank you so much. I should try to give you a short description of how 2curex can help cancer patients. And our tagline that you can see here on the slide, namely that because cancer patients are individuals, that is something that we really take serious. And I will show you how we can help these individuals. First, 2curex in brief. We were spun out of the Carlsberg Research Center in 2006. And we were listed at First North, NASDAQ, here in Stockholm in November last year. The product we have, we call IndiTreat. And that has been developed and tested in more than 900 patients. Actually, now we are beyond 1,000. And what it does is that it selects the right treatment for the individual patient. We are in clinical validation of this technology in colorectal cancer and in ovarian cancer, and that is in Denmark, Germany, and the UK. And lastly, we have a strong financial position. At the IPO, we raised what we asked for, 18.3 million Swedish. And here in March, we announced that we have now received a grant where we have got 50% of it already, of 31 million Swedish. And we are present, and that's a very important aspect of 2curex. We are at hospitals, and today we are at major hospitals in Denmark, Germany, and the UK, and expanding. So why should you invest in 2curex? If you haven't done yet, you should. And why is that? Because there is a tremendous need for increasing the efficacy of cancer treatment. Today, it is for first-line treatment only 30%. There are different ways in which that can be achieved. One way is that you develop new drugs. And what can be said there is that developing new drugs have the problem of a very high attrition rate and very expensive clinical trials. However, there is obviously, as the last line indicates, there is high risk and also high gain. And the gain will be obtained through a buy-up, in most cases, by a pharma partner after clinical evidence have been shown. Then there's the 2curex way, because we are not a drug discovery company. We take approved drugs, of which there are many, and highly effective drugs. We save patients every day. The only problem is that we need to match the right drug and combination of drugs with the patient. In the last line, I've shown that we have a low risk. We also have to admit that as compared to the drug discovery companies that really make it, the few percent, the gain from 2curex is not at that level. So it's medium gain. I will show you what the market opportunity is. And this gain will be obtained already 2 years from now. In 2020, we will launch the product in the Nordic countries, Germany, and in the UK. Now I have a small movie here that sort of shows the principle of the IndiTreat.
Is often thought as one disease affecting different parts of the body. But in reality, there are actually more than 100 different types of cancers, and there are more than 400 different drugs and drug combinations available. This makes the task of choosing the right cancer treatment very challenging, and that challenge is reflected in the response rate among patients being treated, which today is around 30%. Often, the oncologist only has one shot at choosing the right treatment, and it usually takes months before they can see any results. This is where IndiTreat can assist. IndiTreat is a method that focuses on finding the perfect treatment for every individual patient. A small sample is taken from the patient tumor. IndiTreat then expands this sample to hundreds of microtumors and tests all available treatments individually. In a matter of days, IndiTreat identifies the effective treatments from the ineffective ones. This is done by measuring the growth of the individual microtumors. An effective treatment will kill the tumor cells, which causes the microtumor to shrink. IndiTreat then presents detailed data on every treatment tested. This helps the oncologist to choose an effective treatment for every individual patient. IndiTreat will increase the number of cancer patients responding to treatment. 2curex, because cancer patients are individuals.
To present it a little bit differently, I would say that with IndiTreat, we want to do for cancer what antimicrobial testing have done for infectious diseases. You probably all know that if you have an infection, or your child, then you take a small sample from the mouth most often, and then you will spread it on an agar plate, and then you have different drugs. The drug that works, you can see that clearly, that's what you give to the patient. In essence, you take the drug that will kill that bug. We do the same. And what that has meant to infectious diseases is phenomenal. Before the test and penicillin we had, actually more than 50% of us died from infectious diseases. Now you see that have declined. We have an issue with resistance, but we are still below 10% mortality rate, whereas cancer is just sloping up. Luckily, heart diseases, that's going better. And how we're going to do that is, as it was presented in the movie, we take a small sample from the patient tumor, the tumor itself, or the metastasis that has spread to other organs. And we make thousands of small microtumors that have the same properties as the tumor in the patient. And then we screen a whole panel of drugs and combinations thereof, and you will see here, that small tumor will grow. This is what happens in a matter of days, and an effective treatment will simply kill the tumor. So what is it that we have shown here? Point one, very effective drugs are on the market. This is important to state. People are saved, as I said before, on a daily basis with fantastic drugs. The problem is that they do not work in all patients, and even one drug does not always work in the same patient. So we may change the drug that the patient receives. So, and secondly, this is the issue. We just need to get that matchmaking to work. And obviously, this low response rate is a major problem, not the least to the patient, but also to the caregivers and society. So IndiTreat is the matchmaker between drugs and patients. These microtumors, this is actually 1 millimeter is kind of sort of from here to there or to the door, so they're very small. The only reason I show you this is that these microtumors are highly heterogeneous, exactly as it is in the patient. We have loads of clinical and scientific data that supports that they are as the tumor in the patient. And as you saw before, normally this is the growth we will see within 10 to 11 days, and with an effective treatment, it will stop growing and even completely disintegrate. Now, 2curex has not invented 3D microtumors. What we have done is that we have patents and knowledge to make it clinically applicable. There is now a load of data, some we have generated, some that's generated in the scientific environment, that shows that this is the way to design treatment. Actually, this paper is from Science just a few months ago. We are currently in 2 major cancers. The first that we have worked with is colorectal cancer. And what can be said of colorectal cancer is that it is the second most cause of cancer in women and the third most common in men. So high prevalence of this disease. About 1/5 of the patients are diagnosed with metastatic disease. That is what they die from. And we have this response rate of 30%. The median age at diagnosis is 70, and we have a 5-year survival of 63%. And this is the number. We are approaching 500,000 new diagnosed colorectal cancer patients in Europe every year. Ovarian cancer, often called the silent killer. Here, when we get the women in, actually 75% of them are diagnosed with metastatic disease. It's a devastating situation. And of these, when we start treatment, 80% of them will relapse. So the disease appears again, and they show resistance to the treatment we have provided to them. They are younger. We see a lot of patients in their 50s, even in their 40s. And their 5-year survival rate is unfortunately lower than in colorectal cancer. There are not as many close to 70,000 in Europe, but because almost all of them will get a medical treatment, there's a huge business opportunity. Now, last year we finalized a prospective study where we have had loads of colorectal cancer patients through. The way in which we conducted the study was that the patient comes in and the physician will decide on the treatment to give the patient, irregardless of our test. We just treat them as they normally do. Then we will test in parallel and see whether we would have picked this treatment. In this case, we would not have. We would not have, red is bad, I should say, whereas dark green is good, that's sensitive. So this patient was only sensitive to a combination of 4 drugs. Unfortunately, this was picked and we lost the patient after 4 months. We have a whole lot of data there. I've just shown you a small clip of it here where we have a number of patients and some standard treatments. And the only thing you should get from this is that there's no single treatment that works in all patients. And unfortunately, some of the patients, there's nothing that we can offer them. And that's what you see there as well. Because of the prospective study we have done, where we have shown that we can at least increase the response rate to twice what is historically available, the 30%, we have started an interventional study where we will test the patient, find the treatment, and then treat the patient. And I should say, if I just jump to this is how the patient looked before the patient went into the trial. These are standard drugs, and there were no response, maybe a little response there to oxaliplatin. Then we will add a number of what we call off-label drugs. These are drugs that are on the market, but not used in colorectal cancer that much. So we will sort of go beyond the standard treatment because they do not work anymore. In this case, it is a combination. It's called TAS-102. The patient will be treated with. This is how the patients look in the sense that we take a CT scan of the patients that come in. They have metastasis to the liver, and you will see these dark areas. That is liver metastasis. With regard to the ovarian cancer, I'll just mention that we have sort of transferred the colorectal knowledge we have into the area of ovarian cancer, and because metastases are such a huge problem, it was very important for us that it will work with both metastasis and the primary tumor, and it does. These are the small microtumors you will see. The metastases from ovarian cancer, they sit in most cases in the omentum. Some will go to the liver, but most of it sits there. And we are running that study in these sites. We have clinical advisory board, highly skilled surgeons and oncologists, and then our hospital centers at the moment is University Hospital Bispebjerg in Copenhagen, medical center in Hamburg, it's called Universitetsklinik Eppendorf, Hamburg, and then an oncology center in Vejle, Denmark, Queen Elizabeth Hospital in Birmingham, and Rigshospitalet in Copenhagen. We have a partner, the biggest colorectal cancer patient organization called Europa Colon, that we work closely with. And here is our management and our board. I should say that we are in Germany, where we, as I mentioned before, we have presence in Germany, and actually one of our founders is German. We have 2 Germans on our board, and we have a board with a very effective network into both the clinic, diagnostics, and finance. Concluding on sort of what it is we are working towards, namely launch of IndiTreat in 2020. We set that at listing, and that still holds. And here's the problem. The 30% response rate, or you would say the 70% that doesn't get a response with first-line treatment. What we want to do is to match patients with existing drugs. And I should say, when new drugs come, obviously they will just go in and be tested as well. So we call it the functional matchmaker. With regard to the market, it's about 10 billion. Actually, a few months ago, I presented it was 7 to 8 billion. It has gone up because we now have ovarian cancer, and it might actually be higher, but that's sort of the number that we see now with those two cancers. There are competition. Most of the competition we see is from academic institutions, and that we really favor because that supports the whole concept, and we have protected it from that basic discoveries and out to the patient. And I mentioned to you that we are in hospitals. This is very important for 2curex. From day one, we were born into hospitals. We want to be close to our customers, patients, doctors, and the whole hospital system. Just get in and learn how the decisions are taken is extremely important. And also for the subsequent marketing, we then are in the major centers in these countries. We will expand into other countries. Actually, all the countries where we launch the product, we want to have presence with regard to test sites. And then I mentioned to you that we have a sound cash position, and we expect, as said, to roll out IndiTreat in 2020. So, in short, what we have achieved, the listing, we got what we went for. We expanded our management team beginning of 2018. We have launched a clinical trial within colorectal cancer, now enrolled 13 patients. We have secured the 3 million from EU, and of those we have now received 50%. And we just launched a clinical study within ovarian cancer. What should you expect in the next period? We will actually increase our communication. And I must admit, we haven't been too good at that. That is something that we are really bumping up now, is effective communication. Also because we need to show that we are not a drug discovery company. We need to position ourselves. We have a different risk-reward profile, and we need to work on that, and we will. CE-IVD will be registered here after summer. We will expand into further centers in these countries, and then we will finalize the colorectal cancer trial next year and launch IndiTreat for colorectal cancer in 2020. And the year after, we expect to finalize the clinical trial in ovarian cancer. So if I should make sure that you get something from this talk, then it would be this. 2curex IndiTreat, we matchmake existing drugs with patients. We have a risk profile that is different from drug discovery companies, and there are financial gain to be obtained in 2020 by launching it in the Nordics, Germany, and the UK. And with that, I thank you for your patience. Well, before, I would just say, as Johan mentioned, I have some small flyers here that you're very welcome to take. There's not that much mentioning of ovarian cancer because that's only 3 weeks ago. That will be in the next. Thank you.
Thank you, Ole. I think we could give him a warm hand because that was great. This really sounds exciting. The prospect of making cancer treatment more effective, I mean, it affects millions and millions of people around the world every year. I'm curious as to what kind of interest do you see from external actors in the oncology field when you come out and present this?
The first the oncologist says is, why haven't anybody done it before? It's so obvious. And the quick answer to that is that people have tried it before. Actually, it's been tried way back, probably in the 80s and 90s. But the problem was that there we didn't make full microtumors. We had cells sitting on a flat surface, and that's not how solid cancers grow. So you need to recapitulate the real tumor, and that's new. So loads of interest, and it's also therefore we've been able to get into these major oncology hospitals, and I should say these trials are investigator-initiated, so the hospitals are also taking some of cost and responsibilities, and that's because they believe in it.
And is it also, do you get contacted by more clinics that want to participate, or is it that you have to seek them out to present and pitch your concept to them?
Both. Both, I would say. In many ways, some of the partners we have, they are a little bit marketeers for us within their own environment. So they will say, you should go to there and there. We have also contacted some ourselves, but actually the centers we have, that is some that have come to us.
And the indications, you started out with colorectal cancer, which is a huge market, but what made you decide for exactly that indication to start out with?
Coincidence.
Coincidence?
I would say, because we had developed the technology, and then actually I went to the University Hospital Bispebjerg in Copenhagen. I said, guys, we have this technology, what cancer should we look at? And there was a clear message, why don't you try colorectal? We have so many patients, you can get both primary tumor sitting in colon and metastasis. And then we did. So it's not such that the technology from the very beginning was only for colorectal cancer. No. It was solid cancers, and then it was, we got the right partners early on, and therefore we worked on that. We then decided that we really wanted to get a solid understanding of colorectal cancer. We didn't want to go into all kinds of cancers. We want to have the right clinicians on board, the right hospitals, get the technology to work with colorectal cancer. So we've done several years studies with that. And then first now, when we see that it really works and we are in the final clinical study, well, okay, let's try to go to the next.
And what made you go for ovarian cancer in the second phase, so to speak?
I think that's not coincidence. Actually, there was a bit of thought behind it. There is a tremendous need. It is another population group, as you see, that these are younger women. Most of them are sort of working, and actually when you get a patient in that is maybe in 30s or 40s of kids, it's sort of doing something to you, and there's actually not good guidelines for treatment. There's just been published a major study where they've looked at both in Europe and in the US. First line, there seems to be some consensus, but thereafter, no. Okay. So there's really a need for a technology that can find the right treatment. So I think that was the major drivers. And then we got in contact with Rigshospitalet, and they agreed that this is a major problem. Yeah.
And speaking of guidelines, you do the test. You can test hundreds of drugs, as I recall it, within the test, and also work with, like you said, off-label. So that's experimental drugs that are not on the market yet, and so on.
Well, no, off-label means that they are on the market, but they are approved for another cancer entity. Okay. So an oncologist can decide, I want to use it. There is a barrier, though, because there are hospitals that say, we are not going to provide it. Even though it's approved, we won't pay. Okay. So this will be different from actually region to region. Even in Denmark, we have, they are sort of in the southern part, they have a different view than in Copenhagen. So, but we can always test them, obviously. And what we've seen, if we see a clear response, then it's difficult to say no. Yeah. And in Germany, it's different. There, they actually have a right to be offered a drug if you have, if you can prove that it works, or you can make it highly likely. So we have got some discussions with people with investigational drugs, some that are not on the market yet, and that is an opportunity. But we just think that there are so much on the market that are highly effective if we just find the right patient.
Yeah.
So that's sort of where our main focus is.
But this way then, to test off-label, like you say, off-label for indication that they're not actually approved, this should mean that there's a high value for drug companies with a drug that's, for example, approved for ovarian cancer, but not for whatever cancer, and then your test could show that it actually works for that as well. That's a huge value proposition for them.
Yeah, absolutely. And you can say we can do sort of a pseudo clinical trial for them. We can combine it with known drugs, and then they have sort of a good start to go through an approval process.
And solid tumors is the main target, so to speak. And what would you say? Can you give any indication as to what comes next?
What comes next? I can say what doesn't come.
Yeah.
And that is we will only stay in solid tumors. We will not go into leukemias, blood-borne cancers. That's not us. We are looking at other cancers, but I would wait with that.
Okay.
Because there could be some insight to that.
Like you said, you will be better at communicating with the market, so we'll have to wait for that then. Yeah. I'd like to ask if there is anyone in the audience that has a question for Ole.
How are these trials staged? What is it that you need to show?
Okay. With regard to the colorectal, that is the furthest, there we now, I should say, these are patients with metastatic disease that have had 2 lines of treatment, and they are still progressing. So what we need to show is that we, from needle biopsies, can make 3D microtumors. We need to show that we can screen these drugs and that there is a favorable progression-free survival. So that's the endpoints. There are some technical endpoints, and there is also an endpoint that relates to the efficacy in the patient.
Anyone else? Yeah?
You say you can test, in principle, all available drugs. But then you can also test combinations of drugs. And then there is an enormous amount of combinations.
Yes.
Does your technique take care of that amount of combinations?
Yes, I mean, even though there are hundreds of drugs out there, there are some that we say that doesn't make sense. I mean, there are some that are discarded. And actually, the clinical trial, there's a list of drugs that the oncologist can tick off, that we know that there are some studies. It could be a phase 2 clinical study that shows that there probably is an effect of this drug in, say, colorectal cancer. So there's a filter put onto it. And then we will normally, if we take some newer drugs, we would combine it with some standards. There are some workhorses in colorectal cancer that a lot of the patients will receive. There's a 5-fluorouracil, there's an oxaliplatin. Some of these drugs will often be used together with some of the newer drugs. So the design of the combinations, there are also some thoughts into it, because as you say, if there are 100 and you have 4 drugs, then you can start to calculate. It will be an enormous number. So we will have to, there is a design that the oncologists are involved in. Then that message will be sent back to the lab in Copenhagen, and then we have a robot that will make all the sort of arrays that are needed with those kind of combinations.
In regards to that, maybe you should be in contact with one of the tech giants of Silicon Valley for the big data handling, because it sounds like it could be a lot of data there to process.
I mean, actually, I probably should put that into the next. We have something called IndieBase, and that is a database where we have all the patient data from these 1,000 patients, all the pathology, the biochemistry, the scanning, how they're being treated, the outcome, and obviously our results. And we also have a biobank, and we have rights, ethical rights to store patient material, so we can take that up again should the patient come back or should new treatment options appear. But you're quite right, it is an enormous amount of data, and we are sort of discussing how can we use that. It could be that when we treat a patient, we would then compare that, obviously, to all our data sets, and then come with not only result of that, but results of other patients that obviously are anonymized.
Yeah. Sounds really exciting. I have one final question before we have to move on.
You can show surprising choices of drugs, but talking about these workhorses and that only 30% will respond, do you expect clinicians not to use these workhorses when you have shown that they are not effective, or will they still, for other reasons, security reasons, still treat patients with the seemingly ineffective drugs?
That's a tricky one. There's no doubt that there is a barrier to go beyond guidelines. If you say that the guideline for colorectal cancer is FOLFOX or FOLFIRI some places, and you say, no, we're not going to do that. So I think first line will be tricky. I think a number of clinicians would say, well, let's do it at second line. We obviously want to be in at first line, and I think when they start to see the result, I hope that is possible. Because often what happens is that not only are they not effective, a lot of the first line, but it will provide resistance for the subsequent treatments. For instance, if you take FOLFOX and the patient doesn't respond, then we have a problem getting effect with FOLFIRI afterwards. But I'm sure if we had, and we have shown that, if we had taken FOLFIRI first, it would have worked. So I think guidelines are great in many ways. So we are really certain that we all will get the same treatment. But the problem is that we are not the same. So I think what we try to do is to get this into guidelines. So that would be the final goal for 2curex, is to get IndiTreat into the guidelines and say you will have to do an IndiTreat test. As we have with some tests. I mean, in colorectal cancer, a KRAS test is in the guidelines.
That would be an exciting day when that happens.
Yes, then we pop a bottle.
Yeah, or two maybe.
No.
Ola, I'd like to thank you very much and wish you all the luck. And thank you for a great and interesting presentation.
Thank you.
Thank you.